Hello, everybody. Welcome to Global Response to COVID-19, webinar number 9. Webinar number 9. So this meeting is supported by the Panamerican Trauma Society, the American Association for Surgical Trauma, International Relations Committee, World Coalition for Trauma Care, and sponsored by University of Miami and Virginia Commonwealth University, VCU. I would like to welcome everybody join this webinar. Just remember this webinar is being recorded, can be watched at the Panamerican Trauma Society's website afterwards. And remember, if you are in this meeting, you agree to have your image recorded and everything you say can be listened afterwards. I'd like to welcome Dr. Michael Butanos, Chair of the AAST-IRC, to welcome our panelists today.
Thank you. Welcome, everybody. Valeria, if you could put the list of all the panelists on the slide, would be great. And so, Dr. Antonio Martos will present the speakers. As far as the panelists, we'll start by Dr. Raul Coimbra, Executive Director of the World Coalition for Trauma Care, Surgeon-in-Chief at Riverside University Health System Medical Center, and Professor of Surgery at Loma Linda University School of Medicine, California, in the United States. We also have Dr. Felipe Vega, President of the Panamerican Trauma Society and trauma surgeon in the Department of Surgery at Hospital Angeles Lomas in Mexico City. We have Dr. Esteban Fuanini, who is the Panamerican Trauma Society Treasurer, Director of ATLS in Bolivia. He is a Director General of the Clinica Fuanini in Bolivia. We have Dr. Ken Bofar, Professor Emeritus, Department of Surgery and University of Witwatersrand, and Trauma Director and Academic Head of Mill Park Hospital Academic Trauma Center from South Africa. We have Dr. Sandro Rizzoli, Medical Director of Trauma at the Hamad General Hospital, Editor-in-Chief of the Pan-American Journal of Trauma, and co-editor of the Journal of Emergency Medicine of Trauma and Acute Care in Qatar. We have Dr. Tina Gardner, Director of Trauma and Consultant General of GI and Trauma Surgeon at Oslo University Hospital from Norway. Of Dr. Marcelo Ribeiro, Professor of General and Trauma Surgery at Pontificia Universidade Católica and Chief of Trauma Surgery at Hospital Moraia, São Paulo in Brazil. We have Dr. Alan Guo, Professor of Surgery at Sonny Jacobs School of Medicine and Biomedical Sciences in Buffalo, New York. And I believe we're also going to be joined by Dr. Hayato Korihara, Associate Professor at Humanitas Research Hospital at University of Milan, Italy, Head of Emergency Surgery and Trauma Section at that university. These are the main panelists, and take it back to Dr. Martos to introduce the speakers.
Thank you, Michael. The presenters today are going to be Dr. David Spain, the President of WCTC, American Association for Surgical Trauma. He's a David L. Gregg, MD Professor, Chief of Acute Care Surgery, Associate Division Chief of General Surgery and General Surgery Program Director, Department of Surgery in Stanford University, and Trauma Medical Director at Stanford Healthcare in California. Also going to have Dr. Thomas Scalea, Executive Director of the Pan-American Trauma Society, Professor of Surgery at the University of Maryland School of Medicine, and Physician Chief of the Adams Cowley Shock Trauma Center. And also Dr. Nicholas Namias, Florida Committee of Trauma Chair, Professor and Chief Division of Trauma, Acute Care Surgery and Surgical Critical Care at the University of Miami Miller School of Medicine, Ryder Trauma Center, Jackson Memorial Hospital in Miami. They're going to be speaking about trauma care in the times of COVID. So now I'd like to ask Dr. Raul Coimbra, the Executive Director of the World Coalition for Trauma Care, to welcome our international society, the entities and societies that join this webinar. Dr. Coimbra, please.
Thank you, Antonio. As I say every week, it's a tremendous pleasure to see this effort come to fruition. As you can see on the screen that's being shared with you, the number of international professional organizations under either the Pan American or the World Coalition or part of the International Relations Committee of the AAST. I again applaud the University of Miami Division of Trauma and you personally, as well as Michael Abutanos from VCU to take the lead on this effort, and welcome everyone. Thank you.
Thank you very much, Dr. Coimbra. So let's start with the presentation. So first, Dr. Scalea, please start the presentation. Thank you very much for joining us. Here we go.
Next slide, please. In the trauma world before COVID, we saw about 7,500 or 8,000 trauma admissions a year. By US standards, that's pretty fair. I realize that's not huge by some South American standards. We were up to recently about 25% interpersonal violence, which was largely gunshot wounds. Like everybody else in the US, about a third of our patients were older people with ground level falls and many comorbid conditions. And the rest were vehicular crashes, including pedestrian strokes, some high speed, some low speed, and the last 5% was a little bit of everything else. Next slide. Now, when COVID happened, we have a 14 hospital system, and we made a very clear decision to franchise COVID care, not just at the mothership, but throughout the entire University of Maryland medical system. So we have ICUs in all of those hospitals. We set up triage guidelines. We set up centralized care algorithms. And we didn't bring every sick person to the University of Maryland, the downtown hospital, but we did bring every really sick person downtown. So we have only about 100 COVID patients, but 80% in the ICU, 50% of the total patients are ventilated. And yesterday we had 23 patients on ECMO, 20 of whom were COVID positive. So we have really concentrated the very sick people on the downtown campus. We only have 25 ECMO circuits, so anticipating the need to continue to go up, which I think it will, we are going to try to get up to at least 30 circuits because I feel like we're going to have 30 people on ECMO pretty soon. We're still in the surge. Next. Because we brought all the very sick people here, we had to deploy surgeons to the new ICUs. In the big ICU, we have 6 faculty per week making rounds, and so that stole a lot of the surgeons from the trauma service. We collapsed 3 trauma teams and Sharon Henry's soft tissue infection service into 2 larger services, and we took faculty on each of these 2 services and rotated them every 3rd night for 12 days. So you were supposed to be 24 on, 24 off, 12 on, and then go back to 24 on, 24 off. But as things have started getting busy again, the 24 off is just a myth. There's just too much to do, and everybody pitches in, and I mean everybody pitches in. So what we really have now is kind of one big service for the whole hospital. Next. We were quiet for about 2 weeks when COVID hit, and then things really started picking up again. Interestingly, the low-speed car crashes stayed away. All we see now are high-speed vehicular crashes, motorcycle crashes. We've seen a big spike in suicides, and I mean not kidding around suicides. A couple of times ago when I was on call, we had a young lady jump off a 5th floor balcony trying to kill herself. We had a person take a samurai sword and stab himself, and the sword came out his back. People who are really badly injured, and the penetrating trauma is now very much back to our usual levels in the spring. Next. We've changed the way we care for patients. We've really limited what you guys would call ED thoracotomies, what we call TRU thoracotomies. In the past, I had my own opinion, but I didn't impose it much. As we have gotten busier and we are trying to preserve PPE and limit exposure, we've come down to some very strict criteria for opening somebody's chest. For blunt trauma now, unless you've got a positive pericardial fast, and I did this last night, you get a zone 1 Reboa and closed chest CPR. We're just not opening people's chests for that. A patient that comes in with cardiac arrest, we're short on blood. They get no blood transfusions until they at least get ROSC. We have limited resident participation in resuscitations and airway management in an attempt to preserve our PPE and bring some better order to things. When somebody gets intubated, we are very concerned in the TRU, in the bays, about aerosolizing potential COVID particles. The ET tube gets clamped, and then they get hooked up to the ventilator. Intubated patients that go to CT scan no longer get bagged. They get transported on a ventilator. We've become really sticky about PPE use, both mandating that people use it and trying to preserve it. We recognize we still owe people an education. The hospital wanted me to mandate that only one resident could scrub on every operative case. And early on, I had a very, very good PGY3 from that was rotating that said, well, I guess I don't get to operate since the PGY4 is going to. And I said, that's just not fair. So we are trying to balance this to get people education. And every morning we have what I guess we now call a safety huddle. I hate that term. But we have a meeting in the morning in the TRU to go over the issues around the use of PPE, because we're just so mental about being sure that people are protected. Next. Any of you that have been up to the shop, this is an old picture of the TRU. In the background, you see Sharon Henry talking to Dave Gens. That's a young Tom Scalea in the forefront. And that's what the resuscitation unit looked like, very similar to many people's shops. It was a big open area. At that point, we had 10. We now have 13 individual trauma resuscitation bays. And for people that have been here, it looks a lot different. Next slide. This is what the TRU now looks like. Everything is in plastic. We have every bay isolated in the best way we can as we try to practice medicine in a different way. Next. We have these signs everywhere. Even after a negative COVID test, N95s, a PAPR, or an eye protection is required for every patient contact. There's one of those. Every time you turn around, you see this sign. Next. We also realized we didn't have any rooms with doors on them. We have no negative pressure rooms in the TRU. We only have one room, that's Bay 13, that actually has a door. So Bay 13 has become the place where patients go if they are COVID positive. It's not great. It's the best we can do. You see, there's our tech Dan in there waving, and we're cleaning up after a patient has just left. Next. We took one bay and that made it the supply place. That's where the equipment gets stored. It's where we have PAPRs. It's where we have the isolation gowns. We took one place, and there you see, instead of dawning, there's Dan taking a nap in the chair. So now it's Danning, I guess. And we are doing this to try to be sure that we utilize the PPE in an intelligent way. Next. These are the doffing stations. We have one table split between each of two rooms. And as you come out of the bay, there is a spotter there to help you out of your PPE and to give you hand sanitizer and to walk you through getting undressed so you can stay safe. Next. And since we have these open bays, we have one side where you enter, next, and one side where you exit. You exit next to the dirty table, so we limit contamination to the greatest extent possible, and you keep seeing the signs about N95s and eye protection. Next, please. We have these, when we do an aerosol generating procedure, we look at the clock, that becomes a hot zone, an intubation, a chest tube, and for 30 minutes, you can't go in unless something terrible is happening. If you're in, you stay in an attempt to try to keep cross-contamination at a minimum. Next. Now, it's really kind of a mess. Communication is, for us, almost impossible. I was on call last night. It's impossible to hear anyone else. So we got a bunch of walkie-talkies to communicate from outside in, and they were fabulous. And we got to use them for almost a day before the suits took them away because they said the channels aren't secure, so you can't use them in a patient care area. We finally had a good way to communicate. That didn't last. We have no equipment in the bays. Everything has to get delivered. We had a bunch of sick people last night. Everything gets shoved in under the plastic. Central line kits, blood, hypertonic saline, everything has to be imported. And as we are trying to do this safely, for me, and so much of my practice was putting hands on the patient, that's so much harder, particularly if you're outside the plastic. Not only can you not touch them, you can't even really see them very well. Next. This is how we've decided to communicate. Somebody on the inside writes stuff down on a piece of paper and tapes it up to the plastic. There's the vital signs, the medication. Why we've got a crown on the plastic is not clear. I guess we thought that was a good idea. If you want something, you write it down on the paper, you stick it up, and then somebody runs and gets it and passes it under the plastic. That's how you order stuff. Next. We have only one senior person inside the plastic wall. That's either me or my fellow or my PGY4. We want to have somebody, and once you get in the plastic, it's hard to have a global feel for what's going on because it's too tight. And so somebody stays outside to try to get an overall perspective. And like last night, we're in the middle of a resuscitation. Somebody runs the kid in who just walked in with a gunshot wound to zone 2 of the neck. It's a good thing that we had somebody outside the hot zone to be able to provide care. So we end up with a junior resident, 1 or 2 nurses, a tech, 1 anesthesia attending, and that's all that's inside. Next. This is what it looks like. The patient comes in, we roll the plastic down. You can see through the plastic sheet, though we can roll, if we need privacy, we can roll another piece of plastic down to block that. It looks very ordered. It's supposed to be. Next. But that's kind of what it looks like. I walked, this is me last night with my back to the camera. I wasn't very happy. I walked in, all of a sudden, it became the usual free-for-all. This was a guy in a high-speed vehicular crash. So we try to do it. We're not always perfect. Next. The residents have gone away. We used to have about 10 residents for each of 3 trauma teams. Many of them came from New York City. Guess what? They don't come anymore. Others couldn't travel because their programs. So we now have about 4 residents per team, less than half. They have stopped making rounds. They stay in the TRU, and it's not really a trauma rotation. It's really a resuscitation rotation. Next. This is my team. That's my fellow Bethany and Will Parker and 2 NPs. Yesterday, we did 3 operative cases and made rounds on 50 patients. Just us. Next. Faculty now run rounds, and I make all of the decisions. What I do is deploy the fellow and the senior residents to operate, and I stop down in the operating room. They call me if they need extra help. The faculty and the APPs do the communications. The APPs do all of the floor care. We are completely dependent on them. They're all getting paid to work 40 hours. They're all working 80 hours, not getting paid any overtime. They're just doing what they have to do. I got all my own operative consents. I talked to the families myself. Last night I called and got a consent for a tracheostomy. We're now doing many more cases with 2 faculty just doing cases. And in some ways, frankly, my life is a lot simpler. Next. So what is it? Well, it's a lot more difficult. It's not as much fun. Social distancing is simply not realistic. The masks, the peppers, the plastic makes communication really hard. Everything takes too long. It takes me about 1.5 or 2 times as long to do all the stuff we used to do. Stabilization, CT, getting to the OR. But we've all banded together. Everybody's in it. And I'm again reminded why trauma is the quintessential team sport. That's our thought from Baltimore. I hope, I'm sure everybody has figured it out in a different way. But I thought I would share those thoughts with you.
Thank you very much, Dr. Scalea. You showed very well how trauma changed at the times of COVID-19. So now, Dr. Namias, so what's happening in trauma care in Florida and in Miami during COVID times?
All right, Dr. Martos, let me see if I can get this share going. And I believe I shared the appropriate window. I'm putting it to presenter, slideshow view. Are you seeing my slides?
Yeah.
Yes.
Okay, great. So good morning, everybody. I'm going to tell you what's been going on with us here at the Ryder Trauma Center, University of Miami. These have certainly been interesting and challenging times. Let's start with some experiences pre-hospital. So we don't control the pre-hospital system. It's run by the municipalities. And pre-hospital, those people were initially lacking in PPE. When we first started seeing them come in, they were coming in with, you know, the coughing, spitting, bleeding patients, and the EMS personnel were not wearing masks, but that's improved. We've encouraged them to get their hands on some masks and tried to provide them with some, and they're coming in better now. But honestly, those guys are still not protecting themselves the way the surgeons are. And I would argue that all of us as surgeons, you know, we have experience from the OR and having a surgical conscience and understanding aseptic technique and contamination. And so we tend to protect ourselves better, I think, than even our medical colleagues. So they're improved, but they're not perfect. Now, some of them have come in with some of these kind of masks, and I'm sure you've seen some of these kinds of masks around the hospital. The problem with these is that these are not healthcare masks. These are industrial masks. So the people you see who wear these sort of N95s with an exhalation valve are still freely spewing their own exhalation all over your hospital and your ICU. And I've had to stop a bunch of people who are wearing one of these varieties and tell them they can wear this, but they've got to put a regular mask over it. They're protecting themselves, but they're not being good citizens to their community and their colleagues, because they're exhaling, and if they're asymptomatic carriers, they're shedding. So these are technically not allowed in the hospital, but for those who do have them, whenever I spot them, I tell them you need to rig up a mask over the exhalation area so that you don't contaminate the rest of us. As far as the trauma resuscitation unit goes, ours does not have the post-apocalyptic appearance of shock trauma that Dr. Scalea just showed us. Ours still basically looks the same. We have started screening all the patients who can answer questions with questions before they come in about cough, fever, illness. We also screen with a temperature. We take an axillary temperature to avoid them having to open their mouths. But we accept that there is what I think we all have to have accepted, a logic gap, right? Because we know there are asymptomatic carriers. So we sort of go into hot COVID mode if they have a fever, answer the questions positively. But if they can't answer or answer negatively, we sort of don't go into a hot COVID mode and have a sort of logic gap there. And the only difference between hot COVID mode for us and not is what room we put them in. Our trauma resuscitation unit is separate from the emergency department. We have 5 glass enclosed bays with doors, and each of those bays has doors, sliding doors in between them that can be closed. We have no capacity for negative pressure anywhere in the trauma resuscitation area, but we were able to designate Bay 1 and Bay 3 as COVID bays, and we can use Bay 2, which is in between them, as a doffing bay. So if they come in and we have a high suspicion for COVID based on the screening, we go to 1 or 3 and we doff in Bay 2, which is in between them. Our PPE includes an N95 basically that we wear for every patient. Even the hospitals, the CDC don't advise this, but I think as surgeons we recognize it, especially trauma surgeries. Anytime these patients can cough, we could be opening a chest, we could have an open trachea. So we wear an N95 for every patient. We wear eye protection for every patient. The hooded coverall suits are available, but even when we highly suspect and are doing an aerosolizing procedure, many of us tend not to use the hooded coverall suit because we're trying to make up for the logic gap, and we realize you don't catch this disease through the skin on the back of your neck. You catch this disease through your eyes, your nose, and your mouth. And so we feel more at risk of contaminating ourselves doffing a hooded coverall suit than by using what we always use. We know how to doff from all of our operations where we come out covered with blood and not contaminating ourselves. So we tend not to use the hooded coverall suits, although they are available. As far as PAPRs go, we don't have them for the trauma resuscitation. So we have been promised some of those at one of our hospitals. I'm waiting to see how that goes before we do it at our mothership, Ryder. Quite honestly, I suspect that those will be so limiting in terms of hearing and seeing and comfort and time that I'm not that enthusiastic about it. And I actually feel very safe with an N95, goggles, a face shield over it, gown, gloves, the usual stuff, plus the respiratory protection of an N95. We really do practice social distancing. We've made it very possible. We Zoom everything. We Zoom our morning report, where many of you have visited us and been to our morning report and to our grand rounds, our M&Ms, and we would normally pack 25, 30 people into the room where we do this. Now we put 1 or 2 people in there and we send out a Zoom invitation, and we do everything. Our morning report, our conferences, our grand rounds, our peer review, everything's by Zoom. I'm on the SICU service this week. At 8:30, there's 1 or 2 people in the classroom in the SICU. And then from afar, we actually have one intern who stays home, who participates in rounds. They gather information by the EMR. They create a template for the note. They present the patients. Obviously, they can't present what they touched or felt, but they can still participate. We Zoom everything. Even floor rounds, we will Zoom to go over the numbers and the talking beforehand so that the walking around is limited to only a skeleton crew and limited touching and interaction with the patients. We've even added, many of us, a phrase to our notes that say physical interaction necessarily limited by COVID-19 pandemic. So this is not a time to be checking for tactile fremitus or percussing the spleen. We only examine what's absolutely necessary. And as I mentioned, some of our residents even round from home. The N95s are an interesting thing, and my question for everybody is, have you been fit tested? Because I suspect a lot of you haven't, or has been many years since you have. And these are 2 of the 3M masks that are commonly available, and these are for healthcare. You can see there's no exhalation valve. But myself personally, the 1860 doesn't fit me. The one that's that blue cone doesn't fit. I went to a fit test recently. I've known it for a long time, but I wanted a fit test again. And that 1860 fits me only if I stay still. The minute I turn around or talk, it leaks from the sides. The 1870, which you see next to it, the duckbill mask, has a much bigger coverage, goes under your chin, up onto your face and around the sides better. And if you haven't been fit tested recently, I suggest you go to your occupational health office and get fit tested to make sure you're wearing the right mask, because it really matters now. And I admit that for years, I never was really too concerned about walking into a TB room wearing this thing for 10 seconds and throwing it away. But now that it's so critical, I'm happy to know which one fits me, and that's the one I wear. So initially, we were all under the great fear of the great shortage of PPE, and we've been very lucky in Miami. We have not really had any terrible shortages. And we had a bunch of improvised PPE donated from the start. And I'll tell you, people have good intentions, but we've had people give us 3D printed frames for face shields, but every one that we've gotten, you can't see through the plastic. It's just not optical plastic and everything gets blurry. We've had everyone devising homemade N95 masks and 3D printed N95 masks. We even have from our own research arm, someone working on a 3D printed N95 mask, trying to create the filter using the halyard OR wrapping fabric. The good news is I don't think we're ever going to need them. The supply chain's been very good, and we have genuine 3M and Cardinal Health and halyard N95s. And when I say we have enough, I say we have enough because the hospital has slowly developed reprocessing methods. Now, I'll say that us surgeons did our reprocessing methods faster, but I'll show you. This is a picture of a reprocessed mask from mine, and our hospital system makes it so that I need to write my name on the mask, and I put it in a brown paper bag after I've used it for a day, and then they hang them all up and treat them with ultraviolet light. They then put it in a white paper bag and return it to wherever I brought it to. So in my case, I do it in the trauma operating room. And this is the mask I wore today for the SICU. It has 3 marks on it, so now it goes in the garbage and I get a new one. In terms of PPE, I told you I just rounded in the SICU today. And, I hear what they're saying about using simple face masks except for highly aerosolizing procedures, but I'm not buying it because I think in what we do, we never know what we're going to get into. So all of the doctors really are wearing an N95 anytime they're in the ICU. But not all the nurses are doing it. They're finding it harder, I guess, but we wear an N95 at all times in the SICU. Until the hospital had its process, we went through some various things, and this is the steamer that's sitting out in our office. And I'll tell you, a mask steams very nicely. You can put an N95 and steam it for a half an hour, nothing happens to it, comes out beautiful, clean. So until they had that reprocessing, we were steaming them. In all actuality, they really had enough to give us a new one every day, but we were in conservation mode, just worried about the future. And I haven't used this steamer since they've had the processing around. But if you are in that mode, you can steam them with very little degradation according to published reports. The picture on the left is some improvised PPE that was donated. That's a bag of 60 face shields. So someone, 3D printed a frame and then used some sort of acetate that's see-through, but it's completely blurry. I mean, it looks like it would do the job, but you put it on, you can't see. The one that you see hanging, that single mask, is one that the hospital issued to me. And, it's crystal clear. You can see through it, it's comfortable. So you can't really improvise these things unless you have the right plastic to see through. They've also issued me a pair of lab goggles. That's really what I basically use all the time in a patient area. I just keep them on my forehead, look like Mad Max, and drop them onto my eyes when I'm near patients. So this is the mark of Namias throughout the Jackson Health System now. Wherever you go and find copper on a doorknob, on a wall plate, on anything, it's because I was there. And I'll show you why. I've basically taped up all of our areas where our nurses and doctors might get exposed and high-touch areas to copper. Why? This is something that was recently in the New England Journal of Medicine, and what you see here is a viral titer for SARS-CoV-2 versus time on different surfaces. So you can see that for, and I believe, let's see, do I have a cursor? Yeah. So this is the time if you just have it suspended in aerosol in a lab situation. If you put it on copper, you can see that within, and this scale is rough, but it's by 4 hours, you've gone down to having essentially no viable virus that can infect on a copper surface. Cardboard can last up to 40, 48 hours. Stainless steel, you're looking at upwards of 60, 72 hours, and plastic also 72 hours. So it really makes sense, you know, and those of us who've been involved in surgical infection over the years, you know, have read from time to time about using copper on ICU surfaces. I tried to get my hospital to do it, but it's just too much for them to jump and get everything covered in copper. So, you know, I took it into my own hands, got copper tape on Amazon, and it's the mark of where I've been. Everyone knows now, and you'll find it everywhere where I go, or our residents go, or our nurses go. There's copper on everything. In the trauma bay, what have we done differently? There is no bag valve mask, oxygen only, no assistance. We do not allow bagging. Intubations are done by anesthesia by a senior person. Everybody leaves the room. High suspicion or not, everybody leaves the room. Now the PPE is variable. I'll tell you, when we started, the anesthesiologists all put on the bunny suit, but they have gotten down to basically using a gown, gloves, an N95, a mask covering it, a face shield, a hat, and then they intubate the patient under a plastic tarp. So they're either looking through the tarp or doing a video laryngoscopy. So video laryngoscopy under tarp, or if they have to do a direct laryngoscopy without video, obviously that's not a choice, but video whenever possible. Everyone leaves the room, and we have no negative pressure. They leave the room, and then we come back in with full PPE. In terms of managing intubated patients, there's a filter goes on the tube, and that is, any disconnection happens on the ventilator side of the filter. The tube is never open free to the room. If it has to be free to the room, it's clamped, just like they talked about, just like Dr. Scalea talked about. Tracheostomy anywhere in our system now is almost a never event. Really almost a never event. When I trained here, we almost never trached patients. We really believe that you should titrate the ventilator to the patient's need. And so even though early tracheostomy has become a thing of preference in modern care, there's no good data that does the patient any good. And so we've reverted to this being really almost a never event. Now, if someone's been intubated for a month, they're COVID negative times 1, 2, 3 times, it really looks at this point like they're uncomfortable. We'll go do it under maximum PPE, open, not perk, apnea during entering the trachea, but it is literally almost a never event. And we don't have anybody on a tracheostomy sitting on an open circuit like a trach collar or a T-piece. Everyone stays on a closed circuit, because we have had patients after a 5th COVID turn positive after they've been sitting in a room with an open T-piece or something, or an open trach collar. So there's no more open circuits to tracheostomies. Now, the trauma of the workup, I stole this name. This is not the best course, but I call the trauma workup in this era the best exam. It's a brief exam. You use your senses and tomography. That's the best exam. What does that mean? It means we dispense with the traditional theater of medicine. I think a lot of what we do is theater. What do I mean by that? Well, you come into a noisy trauma bay with a screaming patient. You know, you can't turn off the damn alarms. It's alarming for everything that you know is going on. The ventilator is hissing. The nurses are calling for stuff, and somebody's listening with a stethoscope. You can't hear anything. that stethoscope is theater. We're looking at the pulse oximeter. We might be looking at a fast exam if we're concerned about pneumothorax, but that stethoscope is theater. That rolling the patient on their side and palpating for a step off in the thoracic and lumbar spine, that's theater, because in 2020, they're mostly going for a pan-CT anyway. So that finding of a step off is theater. So in this era, we've dispensed with the theater. Only the decision makers participate in the room. It's not a crowded room. You send in the attending, maybe a fellow, high-level people, and the exam consists of, is their brain working or not? Are they saturating well or not? Do they have palpable pulses and a good blood pressure or not? And we skip the stethoscope, the x-rays. Honestly, we skip the fast exam because we know that we do 990 negative fast exams to get to 10 positive ones. And so although you need to do those negatives to learn, maybe this is not the best time to learn. So we skip almost all of that and go directly to CT. Of course, if the patient's unstable, if they have peritonitis, skip it all and go to the OR. If they're not saturating well, maybe you do a lung ultrasound, maybe use a stethoscope, but go ahead and put the chest tube. No cardiac motion, no gratuitous thoracotomies. So we also have really gotten away from the thoracotomies, which we probably overdid, and we're gotten away from them. In terms of testing, we test 100% of the trauma patients for COVID. Initially, it was with the RT-PCR, which meant you couldn't have a result anytime soon, but you found out later. Now we have the Cepheid platform, and we have results in as little as 45 minutes. We have had cases where the patient has gone to the trauma OR, and they call into the room 10 minutes into the laparotomy to let you know the patient is positive. It's not that it really makes a difference because you still have to use your precautions, but it is nice to know, at least for post-op disposition. The Cepheid platform is great, but the kits are in short supply, and I'm told that as of this morning, we ran out of kits, but we were doing every patient. We are fortunate, we have one negative pressure OR in the trauma OR. The trauma OR was built at a time when negative pressure was still in vogue, but it went out of vogue because of the increased risk of surgical site infections, but we were able to turn one of them back on to negative pressure. So we operate, all of our stat OR cases go to the negative pressure room, and we are not using PAPRs, although we are evaluating it. Electrocautery, smoke is 85% burnt up stuff and 15% water vapor, which could be carrying virus, and it's unknown if smoke has infected virus. It's unlikely that it does, but personally, I'd rather not find out the hard way. So I personally did a splenectomy, nephropathy laparotomy with no cautery, knife and silk, and it did fine, no increased bleeding, everything went fine. We do have smoke evacuators, and they are an option. In the ICU, our trauma COVID positive patients go to the COVID ICU, and this is a problem because those are medical critical care people. We are getting close to having a surgical COVID ICU, which we've wanted from the beginning. They're finally getting it now. They're willing to cave because there are transplant patients who need it, and transplant is their sort of pride and joy. So they're willing to open a surgical COVID ICU where we'll keep our transplants and trauma, any surgical patients with COVID. We do have 2 negative pressure rooms in the trauma ICU, and I suspect before long, those will be COVID ICU rooms when we get more used to this and we're living with COVID rather than running scared from it. Acute care surgery, we're doing limited laparoscopy because before we had to vent the gas to the outside. But we now have a couple of insufflators that are total closed circuit, insufflates and desufflates, all closed through high efficiency filters. So we're willing to do laparoscopy again. The cholecystitis and appendicitis basically stopped coming, but those that did come, we defaulted to non-operative, and I really am sorry to say that non-operative defaulting has caused at least 1 perforated appendicitis. Someone that would have had a lap appy and gone home, got a trial of antibiotics and ended up with a perforation. And I think now with the better tools for laparoscopy with this insufflator, we'll be more willing to jump on it and do them operatively. We need to adjust to a new normal, and I think the surgeons will do better than anyone else because we have the surgical conscience. We know how not to touch our face. We know to cover our nose. We know how to not contaminate when doffing. And there's some similarities to this, to the times that I know Dr. Scalea remembers, I remember, Dr. Coimbra remembers, when HIV started. It was like a plague, you know, everyone was scared to death. And now we don't even think about it. You find out halfway through the case that the patient is HIV, or you don't even find out at all. So we'll get used to it. It's just a matter of using your PPE properly, and I would say hang in there. We'll all be fine. And that's all I have to say. And sorry if I took too long. Did my best.
Thank you, Dr. Namias. Interesting topics. There's some questions here I'm going to answer later. So let's go now to Dr. David Spain. Dr. Spain, your presentation, please, your comments. Thank you.
Eric, can you hear me now?
Yes.
All right. Well, hello, everybody. Thanks for allowing me to participate. It's interesting. You know, some of these things are universal. We've gone to a lot of Zoom testing. Nick, we actually have to get fitted every year for N95, and it always annoyed me because I'm like, my face doesn't change year to year. But now, you know, now I'm glad we actually have been doing it. So I have no financial disclosures, except I should disclose that really these slides are a product of one of my partners, Joe Forrester, who's our associate trauma director. And Joe actually is the real deal. So he was an epidemiologic intelligence service officer for the CDC from 2013 to 15. And he was actually deployed to Liberia twice in 2014 to assist with the Ebola investigations there. And he's also been involved in domestic and international investigations in plague and tularemia, which are both tier 1 bioterrorism agents. And so Joe was actually sent to one of the first Liberia hotspot, or one of the first Ebola hotspots in Liberia, and was doing the investigation there. And their first case was actually in July of 2014, when a patient was not triaged correctly, admitted to the ward, basically contaminated 4 nurses and a physician, all of whom died rapidly within a few days, but not before they transmitted Ebola to 19 people in the community. So the net effect of that was that the people stopped coming to the hospital almost immediately, and the hospital was completely emptied within a matter of a few days because the community was afraid of catching Ebola from being in the hospital. So again, when healthcare workers transmit infection, there's a big decline in faith and trust from the community, and people stay away. And we're actually seeing a variant of that now as we've opened back up to elective surgery. We're having a hard time convincing patients to come in for their elective procedures, even though we're testing all the healthcare workers and the patients. And the hospital's probably one of the cleanest spots you can go to. There's really a concern about catching COVID in the hospital. And as Nick alluded to, we're seeing the same thing, big drop off in emergency general surgery cases, which is a little unusual. I mean, some of the things, you know, maybe, you know, gallbladder problems or diverticulitis, you could see patients tucking it out at home, but it's kind of hard to think that bowel obstructions would drop off, but we've been seeing that. But, you know, the key is really adherence to basic infection prevention. And, you know, we're frequently pretty stringent about it in the highest risk areas. So, you know, in the emergency room, in the ICU. But I think, you know, outside those areas, we tend to get a little bit lax. And as Nick noted, there is some similarity to what happened with HIV. And this is a paper actually out of University of Miami in 1990, so 30 years ago, really right at the height of all the concern about HIV, and when the whole concept of universal precautions really first became promulgated in trauma care. And basically, only in about 16% of the time were universal precautions followed. And it was only about 40% of the time when you were looking at invasive procedures like intubation and chest tube insertions. And again, this is 1990, when, you know, HIV was just coming about. It was still a lethal disease, and we knew very little about it. People still weren't using universal precautions. But really, this is the norm. This is what we should have been doing all along. So when this first started, you know, we have spent a ton of time planning for this. I do, in all honesty, have to tell you that in Santa Clara County, we were the first county in the United States to issue a shelter-in-place order and social distancing, and the effects have been pretty dramatic. We have not seen the volume of COVID patients that the rest of the country is seeing. I mean, it's really kind of bizarre. The Bay Area, which has about 7.5 million people, has had a total of 10,000 cases with about 370 deaths total from COVID. But it's still, despite the low incidence here, you know, planning is still crucial and protection is still crucial. So we, as much as Tom and Nick alluded to, even before this started, we were having a gown shortage because of the some manufacturing issues, and so there was some concern about supplies, which haven't really materialized. But we now have gone to the preferred PPE, which is face shield and an N95 for everybody going into the trauma room, and then our major traumas are called 99s for some reason I don't know of historical interest only, but we've limited like the number of people that go into the trauma bay for the major trauma, and then everybody that goes in has face shield, N95, you know, and full gown and gloves. Everybody's screened by EMS before they come and re-screened when they hit the ER. If they're unable to answer, then we just treat them all as likely to be COVID positive. Just pretty much like Nick said, when we go to intubate, it's anesthesia only in the room, everybody's outside, and then everybody dons and comes in after intubation. I think this is, it's interesting that even though we have an extremely low prevalence, the concern is very high, and people have finally gotten to the point where they're actually using the personal protective equipment that they should have been doing anyways. David Livingston actually just published a nice kind of report in trauma surgery and acute care open, where they, similar to what Tom has described, they basically emptied out their trauma bay, got all the supplies out of there. They set up a hot zone, which is the room, a warm zone, which is the handoff area, and then a cold zone where all these supplies are kept in. So basically somebody stays in the cold zone, hands the equipment off onto this tray here in between the two, and then it's taken into the room as needed. And they've set up, you know, dedicated airway carts and procedure carts, including chest tubes, so that they can keep the main trauma bay from being contaminated. And you know, we group led by Fred at University of Colorado put together a little report on recommendations for invasive procedures. I think this is focusing on tube thoracostomies, but I think the concept is the same. And you really basically want to have a dedicated team that does these procedures. I think both Tom and Nick alluded to the same thing, and then maximum protection for everybody doing these. You know, N95s and a face shield or PAPR, and you know, the PAPR has its limitations, mainly the time it takes to put it on and the doffing, as both of you have alluded to. The only thing we did recommend is to put a little viral filter on the chest tube, and also to use these you know, cable tying gun to secure the tube so it doesn't come displaced and disconnected and spew aerosolized particles. Our residents have done this forever. I always thought it was overkill, and now I think it's a great idea. We also had the same concerns about, you know, conserving PPE. You don't want to waste it, but on the other hand, you have to maximally protect the OR team. And so we, as everybody alluded to, limited the number. We don't have medical students right now, but we've limited the number of people that scrub, basically, you know, in attending and one resident for most cases, just to conserve PPE. But one thing we have noticed, we've had a dramatic drop off in our volume. Our trauma volume went down to about 40% of baseline almost immediately. Like when shelter in place went into effect, you can see just trauma volume dropped off almost immediately. We are seeing some shelter in place fatigue going on. This weekend was nice, and so people were out, so our trauma volume is picking back up, but we're still probably only about 60% of baseline right now. So I think it's crucial to remember that, you know, in this whole thing, you know, one of my, Joe Forrester, you know, kept telling everybody there's no such thing as an emergency during a pandemic. You have to be adequately protected. We got to keep our healthcare workers safe. We got to screen them, keep them out of work if they're sick. Find the weak points in our triage and correct them. And we really have to work on just really basic infection prevention mandates, which we should have been doing all along, honestly. So again, the key thing is we have to remember people will get sick from non-pandemic related pathologies. And so we have to maintain our ability to care for both infected and non-infected patients, and then all the while ensuring the safety of our healthcare workers. And if anybody interested in connecting with Joe, who is really responsible for this, here's his contact info. Thanks.
Thank you, Dr. Spang, for your presentation. You had 3 great presentations covering a lot of topics. Now we're going to have a pool of questions. We're going to ask all the attendees to answer. And this poll question is going to be subtract for the discussion that I'm going to have afterwards with all the panelists. So Valeria, please launch the poll questions. They're going to be 10 quick questions. The number 1, does your country or your area have social distance practice in place? Just click the one answer. Yes, and being respected. Yes, but less than 50% of people is respecting. No, we had that, but already on the reopening phase, or you don't know. Okay. So let's have this about the first question. Click select one. Second question: does your country has or area is currently in a lockdown procedure, complete lockdown? And only a few people can leave home. Everybody else needs to stay home. Yes, and he's being respected. Yes, but less than 50% of people is respecting it. No. Yes, but my country, my area is already on reopening phase, or you don't know. Okay. Question number 3. Where does your area region, what's happening with the curve on your case or positive case in your area? Still increasing a lot? It's increasing a little bit, not increasing, it's a plateau right now. Slightly decreased or very decreased, or you don't know. Okay, so how is the COVID case at your country or your area or state? Another question: how do you treat your patients? You have protocols to start managing the patient at trauma bay and to start managing these patients, or every physician can do whatever they want? Okay, you have protocols, firm protocols, or not? Number 5. Are ER and trauma providers in your facility wearing N95 masks at all times during trauma or ER care? Every time you see a new patient in a trauma or emergency room, are you and all the trauma professionals and healthcare professionals wearing N95 masks? Yes, of them. Yes, most of them. Yes, about half of them. Less than 50% of them. No or unknown. Okay. Number 6. Is your facility performing tracheostomy on positive COVID-19 patients? Patients infected and is positive, is on the ventilator. Are you doing, the test is still positive. Are you doing tracheostomy? Yes, I'm doing open trach on these patients. Yes, I'm doing percutaneous tracheostomies on these patients. Yes, but open trach, but only after the infected patient has 2 negative tests. Yes, percutaneous trach, but only after the infected patient has 2 negative tests. I'm not doing it all, or you don't know. Number 7. Is your facility performing laparoscopic or thoracoscopic procedures on any trauma or ACS patients that could be negative or positive? So yes, I'm doing laparoscopy, all of them, doesn't matter they're positive or negative. Yes, but only when I have a negative COVID test, okay? Other answer, yes, but only after negative CT scan of the chest, okay? Yes, on both positive and negative patients, or no, or you don't know. Number 8. Did your hospital change trauma protocols or guidelines at trauma bay or operating room due to COVID-19? Exactly what Dr. Scalea and Dr. Namias spoke about that. Did you change protocols and guidelines? Okay. So yes, for all patients until they have a negative COVID test. Yes, but only when the test is positive. Yes, but only after a negative, until we have a negative CT scan, then everybody's treated the same. Yes, for all the patients, no or unknown. Number 9, is trauma training to residents and fellows at trauma bay and operating room affected due to COVID-19? Dr. Scalea spoke about that. So do you think that, have you been able to train the residents and fellows the same way as before COVID-19? First question, yes, since some residents and since resident fellows have less exposure until patients have negative COVID tests. So another question, yes, but only when positive COVID tests. Another question, yes, since we have less time to teach until risk for exposure if COVID negative is negative. Another answer, yes, on both positive and negative COVID patients. So is trauma training affected or not? Okay, yes or no, and I have these questions. Or if you don't work at academic hospital, please say you don't do training. And last question, is trauma care at trauma bay and OR affected due to COVID-19? Yes. So do you think the trauma care, the level of care that you provide to the patients is somehow affected? Yes, since you have to protect our team to exposure until patient have negative COVID tests. Yes, but only when patient is positive. Yes, since we have less healthcare professional procedures available until risk of exposure of COVID is negative. Yes, on both positive and negative COVID patients. I do not work in a COVID an academic hospital. Okay, after all these answers, please click submit, so your questions can go to the computer. Okay, a few more seconds to review everything if you want. So the idea is just to check how is your area, how you manage your patients, and discuss a little bit about training. So, and then for sure they're going to have the 3 professors discussing, and the panelists, how is going to be trauma training and during COVID times that are going to last 1 year or 2 years. So, any changes in how you train residents and fellows during COVID times. Okay, so we're going to finish the pool right now. Valeria is going to show the answers, and then Dr. Michael Butanos are going to start the discussions with the panelists. Thank you, everybody, for joining this, answer the questions.
Thanks, Antonio. I'll go very quickly to the questions, so we leave some answer for some time for the Q&A if possible. So, does your country or area have social distancing practices? And so we have about 40% said yes, and it's respected, and about 51% yes, but less than 50% are respecting it. And that's probably what we're seeing as well. And the big question is this being also respected in the hospital or not? Does your country or area have lockdown procedure in place? And about 20% said yes. It's interesting, about 34% said no, we don't have that. I guess also depend on the country. And we've heard from one of our last session how New Zealand had total lockdown and would have a very, very minimal amount of. And so I think South Africa, I will let Dr. Beaufort comment on that afterwards. Big difference. Where does your area or region of practice fall on the curve of daily COVID-19 positive cases? Again, about 40% said it's still slightly increasing. About 30% is still exponentially increasing. I guess it depends on your area. And about 20% said non-increasing and has plateaued. So it depends on your region with regard to this. Do you have protocolized sequential treatment guidelines for COVID-19 patients as a physician? And I think this is a big influence on sharing. About 77% have a protocolized treatment and guideline for COVID-19. We all have benefit from that. And we really hope that these sessions here also have helped with this. Are the ER and trauma providers in your facility wearing N95 masks at all times during trauma or ER? Simply only 43% said yes, 36% yes for all of them. I tell you, here at VCU, not everyone's wearing them. And so only if you suspect aerosolized treatment. Is your facility performing tracheostomy on positive COVID patients? And only about 14% said yes, an additional 8 said yes, but with percutaneous trach. And so it sounds that the majority, about 32%, said no, similar to what Namias said, that basically no in Miami, unless it's really needed. But on COVID positive, it's not like it's a no. 27% is unknown. Facility performing laparoscopic or thoracoscopic procedure on any trauma or ACS patient. And again, about 25% majority said no, 20% yes for all of them, and 21% yes, but depending if the patient is COVID negative. And as we all know, it always puts in the question, is the test reliable or not when you do that? Did your hospital change trauma protocols or guidelines? And about 34% said yes for all patients until they tested COVID negative. About 32% said yes for both COVID positive and COVID negative. And the question number 9, that's about training, a very important question. And is your training for the fellows at Trauma Bay and the OR has it been affected? And about the majority, about 34% said yes for both, whether you're COVID positive or negative. And I suspect that goes because you don't really know who's truly COVID negative still. And if you add that to about 23% that says yes, until the patient is COVID negative, so a significant amount of percentages is basically saying it's been effective. And it would be nice to get into what the panel is asking, how has this been affected? It would be a really good question. Is trauma care at Trauma Bay and OR affected due to COVID-19? And again, we have about 40% saying yes for both COVID positive and negative, and an additional 31% said yes, since you have to protect all team to exposure until the patient have been COVID negative or positive. So definitely the last 2 questions on training, more of a resounding yes. The question is how is it affected? So maybe we take some comments very quickly from the panelist, Dr. Bofar. The question came in before with regard to the whole isolation of the patients, and how is that affected in South Africa?
A fairly unique situation because of a very large number of people living in very, very tight conditions. So we have lockdown, which lasted 5 weeks and has been started to lift a little bit, reinforced with police officers, military personnel, and a 6-month jail sentence if you're found walking out. There is a curfew. You may not work out after 8 p.m. at night. And it is pretty well enforced. Cars will be stopped. You have to have permission to travel. So the lockdown made a huge difference. Unfortunately, when you've got 6 to 10 people living in a room, they can't self-isolate. So you can area isolate, but you can't self-isolate. You also can't keep the lockdown going forever. So we're now at 5 weeks. Our government has put in 5 stages of lockdown where Tier 5 is an absolute lockdown. Tier 4 now allows you to exercise on the street outside of your house for a very limited number of hours each day. And as the cases stay low, they will in fact lift that in tiers. Johannesburg, 6 million people. Currently in our area, there are about 2,000 COVID patients and around 20 deaths total, with an increase in number of patients of 23 per day. And that is with good testing. We've tested screening around 5.5 million of the population. We've done something in the region of about 150,000 PCR tests. The Cape is lagging behind a little bit, so they're a little bit more exponential. But I think we're on the early stage of the curve yet. The lockdown unquestionably worked. What happens after the lockdown and how easily you lift it, that's the next installment.
Thank you. Dr. Ribeiro, in Brazil, how is I know you're big on training and training of residents and students. How is that affected by the COVID? Is it any different from what we've seen in the US?
No, thank you. Thank you for the question. Basically, it's the same. We have most of the medical schools just put the medical students away from the hospitals. And even the residents, we're trying to avoid them to getting a lot of contact with the patients, considering that sometimes we have a lack of equipment, like the PPE for all the residents and medical students. And so we feel like we're already having a very hard situation regarding training and teaching students and residents right now during this pandemic. And I don't think it's gonna get better, at least in a couple upcoming months. So it's a very bad situation.
Does it depend? It's an interesting question. Does it depend on what mode of communication and training you're using? Like, for example, for us here at VCU, we've noticed for when we use Zoom for the conference calls, the number of participation by the resident and the faculty has actually increased. I'm not talking about bedside teaching, but I'm talking as far as the ability to hold conferences and teach, because people are isolating and they're more available. Has anybody noticed that? Dr. Scalea, have you guys seen that in your Zoom calls, or have you not?
It took us a while to get better at that, Mike. And as the quality of the conferences has increased, we are now seeing pretty good participation, yes.
So a very similar question, Dr. Coimbra. Similarly at your place with regard to more and more participation as people are figuring out this technology better?
Absolutely. We started very early on transitioning everything to Zoom. Our morning sign out, our M&M conferences, and all the didactics. Medical students were removed, as you know, in the US from clinical care, but we continued their education through video conferencing. What we are dealing with now is that all the schools in our place, we have medical students, but we have nursing students, PA students, NP students, RT students, and students from all over, all sectors of healthcare. Now they are trying to get back into the hospital, and we are trying to develop strict rules to allow specific groups to come back in a staged fashion, because we don't have PPE for everyone. And obviously, particularly for medical students, they're coming back on the 18th of May in California, but in our place, they are not going to have any contact with COVID patients in the cohorted units.
Dr. Hayat, have you seen anything different from what was commented on with regard to training?
No, actually, in our place, we accepted at the very end, actually, quite recently, that means 40 days ago, also the medical students, last year medical students. And they were very helpful to work in a COVID negative area. While regarding the residents of all specialties, they were part of the team, and actually they had resident team just for COVID area. So they've been really very precious to us.
Okay. Thank you. There's a question. I'll see if Dr. Juanini can answer. This question came with regard to Peru. It said, this is from the Q&A questions. It said, the masks of the industry are good to prevent medical staff infection, but not transmission to patients. If in your country, if you don't have more N95, is it ethical for you to use it or not? In Peru, there are many doctors who are dying because we have problems with N95 supplies. What has been your experience, and how would you answer that to our Peruvian colleagues?
Yeah, we're having a real problem with supply of medical equipment in Bolivia. The price of a standard surgical mask has increased by 5 or 6-fold. It's 5 or 6 times more expensive right now. And actually, we've run out of N95s. We're reprocessing our N95s. Once a physician uses them, they have to separate them, and infectious disease comes by and controls that. At the beginning, some physicians were saying, I'm just using this once and throwing them away, and when I come back, I'll just purchase my own. Well, we can't purchase them. So we find ourselves sometimes having to use surgical masks for certain procedures, And also, the hospital started creating their own surgical mask to provide for visitors or patients when they arrive, which is basically just something to cover their mouth, but they're not industrial quality surgical masks. And it's just because they're not available.
Right. Another question from the Q&A, I'll have to see if Dr. Alan Go can answer. Given the presentation and the recommendation given by Dr. Scalea and Dr. Namias and Dr. Spain and the trauma bay and all the variation we've seen, do you suspect this will remain, these type of changes in our evaluation of our trauma patient after the COVID surge?
This is a good question. I think after this pandemic, after the crisis, we will have a new normal in all walk of our society. Not only some other thing, but also medicine. I just listened to a talk last night, an interview, American College of Surgeons website about telemedicine. And it showed that telemedicine is pretty good and has been there for a long time. And this is a good tool providing care as experienced by some other country like Norway, somewhere else. And I think what we're practicing now for during this pandemic, we're gonna adapt some of this to the post-COVID-19 era. I'm sure about that.
So it's interesting. I think everybody shared those your answer. This is a question came from Dr. Ginsburg from Miami too, actually, Dr. Scalea, and I think it's a good question. It's a follow-up to this. It says, what is your system planning for placement of COVID that continue to test positive in the recovery phase? And have they singled out one rehab center for nursing homes? Because we're talking about systems and how the hospital responds. Now, how about in the post-acute phase? Is that a system response in the nursing home level? That's
yeah, it certainly should be, Mike. We are now just getting to the point where we are starting to get people out of the hospital. One thing we have seen is that many patients, both COVID positive and COVID negative patients, opt to go home, even if we think they should go to rehab. They don't want to be in the nursing homes or the rehab facilities, and they just say, I'm going to take my chances with my family and not go. So it's been sort of weird because we always had trouble getting the rehab hospitals to accept patients. Now the patients won't accept the rehab hospitals.
Right. I have another question, since many of us here online are from academic center. This will be for Dr. Rizzoli. One question came is with regard to, aside from the clinical work, in terms of research project, enrollment of patients, etc., how do you think the effect will be on that moving forward? And how do you think that will affect all the journals?
Most definitely, Mike. I think that there are many casualties to this pandemic. One of them is education. I think that our residents are having less clinical and surgical exposure. And I think that research as well too. So the way we used to do research up to now, the way we are used to teach and train physicians has to change. Like it's a new world. We have seen in research, while there's a proliferation of papers, I wonder how are some clinical trials now having to face this new world. So definitely, I think there are many changes occurring in education and research, not only in clinical care, as you mentioned. Many things are proliferating, like the number of papers, but it's affecting enormously, I believe, the final product.
Dr. Spain, what's your comment on the same question with regard to research, etc.?
Yeah, as Sandra noted, like some of the journals are seeing as much as a 50% increase in submissions right now because people are at home, not working, and and starting to fill the time by writing papers. So there's been a big increase in submissions. But I like Sandra, I'm concerned. We have a NIH-funded study on PTSD, and enrollment's just ground to a halt. and for the last 3 months, and I don't see it starting back up again for another month or two. So it's going to have a huge effect on clinical trials and studies for a long time.
Dr. Spain, what kind of challenge do you see for training fellows and residents in trauma in the next months or maybe years?
Yeah, it's mostly a volume kind of question, right? And like I say, we're down. We're about 60% of baseline in our trauma volume. Our emergency general surgery volumes probably down 25-30%, and we have a moderate elective practice at our group for our acute care surgeons, and that's basically ground to a halt. And I think it'll be 6 months or more before those get back to normal. I'm mostly concerned about our current PGY4s. Our fellows and our 5s are kind of okay. I'm really worried about the PGY 3 and 4 classes that are going to be affected for the next year or two.
So do you think same has happened, for example, with our Italian colleagues or some other places of how we're graduating medical students a lot sooner? This is not something we could afford to for our PGY4s if they're finishing up but they don't have their volume. Is that gonna affect the need to extend, or what kind of solutions do you think?
Yeah, I am on the American Board of Surgery, and this year we made some accommodations for the PGY5s that are finishing, in another month or two. Luckily all our chiefs had hit their case volume numbers already, so the slowdown for the last 2 or 3 months didn't affect them. But I think in some programs that's going to be a major issue. Like I say, the board's made some accommodations this year to account for that, but I'm more concerned about the current PGY 3s and 4s and what's going to happen with their experience. In the United States, 80% of them go on to fellowship, so I think they'll get caught up. But it's a little, as a program director, it's a little concerning about signing off on these trainees and saying that they've had the requisite experience to move on to the next phase.
Okay, I have some interesting question here. We have a lot of people here in this webinar from South America, and I know South America, they have a lot of problems with PPE. Dr. Velasquez, the chairman of the Department of Surgery, University of Miami, had a question. So what's the evidence do you have for that hospital reprocessing methods like UV light or hydrogen peroxide vapor, etc., does not induce problems or be harmful for patients and for the healthcare staff? Any other way to use this, to do the reutilization of this equipment or this PPE, since none of that have been FDA cleared, right? So I'll ask Dr. Coimbra, Dr. Namias that spoke about that, and Dr. Hayato Kurihara that maybe had this issue in Italy. So Dr. Coimbra, then Namias and Kurihara. So what are your thoughts about reutilization of this kind of PPE, and what can you recommend to South America that definitely they're going to have some problem with that once they're still going to reach the peak?
Yeah, so my thoughts are the thoughts of our infectious control department in the hospital. They've taught us in the last 10 weeks or so that there are actually evidence suggesting that both UV lighting and as well as hydrogen peroxide vapor are effective in cleaning up the N95 masks for reuse once. We are using the same process with the hydrogen peroxide to reprocess the filters of our facial masks. As I presented in this webinar several weeks ago, we repurpose a number of CPAP masks with a filter at the end, so anesthesiologists are always protected when they are intubating, and other professionals in the ICU are using the same masks. So all those things that need to be reprocessed can be reprocessed and cleaned by hydrogen peroxide vapor.
So, Dr. Velasquez, who's my boss, for those of you who don't know, specifically asked, does the reprocessing lead to the generation or liberation of compounds that could be harmful to the wearer? And that's a really good question. And I'm hoping the answer is no. I think it's probably unlikely that when you do something that changes the conformation of the molecule of that, blown polypropylene, that, maybe while you're exposing it to the UV light, something's happening. But I think when it's over, I'm hoping that it's okay. And since I'm basically breathing in interstate 95 air for, a good time every day, I think it's probably less dangerous than city dwelling. So I'm not too concerned about it, but it's a really good academic question.
I just want to make one comment. For those that are interested in UV lighting, the University of Nebraska's website has a fantastic document, because they were one of the pioneers in their ID division to use this technology to reprocess PPEs. And according, it's a 90-page document, and they describe it in great detail. And it seems that is effective and doesn't change too much the molecular conformation of the fibers of the material that the masks are made of.
So this, I guess one more thing, this UV light is everywhere and going to be everywhere. It's in places you already don't even think about it, but it's in, there are air scrubbers that scrub the air with UV light. There are pool cleaners that clean the water with UV light. They're showing robots in Whole Foods that are going around and sterilizing the surfaces with UV light. We're opening a new ICU tower next year. I got a tour yesterday, and I suggested they replace some of the light fixtures with the UVC light so we could clean the rooms in between. We currently put a light in the rooms to clean between patients. So why not build them into new construction?
I'm going to ask a quick question for Dr. Felipe Vega, the current president of the Panamerican Trauma Society. Felipe, if you're listening to all the comments with regard to the PPE, its availability, and we haven't heard much with regard to Mexico, are you seeing the same type of shortage that we have seen, and have you used the same solutions that have been recommended here in this session?
Hi, do you hear me well?
Yes.
Yes, we think we have some problems with the PPE here and in some public sectors. Not in my hospital, but we have the same problem that's mostly the Latin American countries. We have it's around 20% of the healthcare workers are infected because of this. So we think we have to change our new model of life, even with the mode not just to treat trauma patients in bay, in OR, and all the social modality of care even in consultation. So it's a new challenge for all Latin American, with all the resources, with limited resources and lack of protocols, and we have to. It's an opportunity to work with, to try to have develop of this that we have for years, a lack of these type of protocols here.
Okay, I have a last question, Dr. Hayato. Dr. Hayato, you mentioned multiple times during the presentation that you had a lot of healthcare professionals contaminated or even pass out, died in Italy. So do you think this is related to use of PPE or misuse of PPE or reutilization of PPEs? Just your comments regarding this topic. So what's your feeling in Italy? You're already going to recovery phase. So tell me your feeling about the PPEs and why did you have a high mortality, or not high mortality, but you had a mortality throughout like healthcare professionals in Italy?
Actually, 170 doctors died, and most of them, they were family doctors. So they were really in the front line, and this especially happened at the beginning. We had less nurses and more doctors. Quite rarely in the hospital. I mean, not hospital doctors. But I give you an example. That's my reality. First, we never went out of stock in my hospital. We have been in a very lucky position. I proposed, I've been in contact with Professor Coimbra, and I proposed to use the filters and the masks that Professor Coimbra showed us several weeks ago. But it was not accepted by my hospital because our chain supply said, no, don't worry, we are not going to run out of stock. So family doctors, and quite not young doctors. But just to give you an example, we had no infection in ICU, no doctors, no intensivists, no nurses. But out of 40 surgeons in our general surgery department got infected 10 out of 40, right? And to tell you the truth, I don't think they got infected by the patients. They were being infected at the beginning of the outbreak because we all stay in open space, and we are quite packed. So it was that was the main issue at the beginning.
Wow, great comment.
Thank you very much. You had great questions, Michael. So all the questions not answered today, you're going to send to the presenters and the panelists to answer, and I'm going to send it back to people that did the questions. So, Michael, I'd like you to make final comments regarding representing the Panamerican Trauma Society, then the president of the Panamerican, Dr. Felipe Vega, the president of the WCTC, Dr. David Dispense, and the president of the WCTC, Dr. Coimbra, to make the final comments, please.
I just think this was a great session, Antonio. I appreciate everybody's incredible comment and experience, and from all the speakers and the panelists. And I think this was incredibly helpful, and more to come with this. Really appreciative.
Yeah, wonderful job again, guys. Thank you so much. I think lessons learned are very important. We need to disseminate this learning points. And I'm glad that I could see Dr. Scalea's face this time, because every week I just see a black screen with his name on it. So Tom, good job. Good seeing you.
Seeing everybody.
Yeah, for me, one of the interesting things is as much as we all hit Zoom fatigue after some of these events, I do think the ability to connect like this, like we haven't done anything like this before. This technology existed, but it took something like this to push us to get together. So I mean, look at this. We have people from Italy, South America, the United States, all connecting, seeing each other, and sharing our information. So the one good thing that's come out of this is that we've realized the world's a lot smaller than we thought, and our ability to connect is even greater.
I think that it's a good idea. Also, if we can change this opportunity of learning to all the residence programs, even not US, Canada, and also in Latin America, and it's a good opportunity to use this with excellent teachers like you.
I just want to make one more comment. Sorry, I know you're out of time, but we need to give credit to people that deserve it. And the credit, in my opinion, goes to Antonio Martos. Antonio started international case discussions in trauma several years ago on behalf of the Pan American. We had people from all over the world participating weekly, and those discussions are still ongoing, and expanding that in times of crisis, such as the Haiti earthquake, and then the fire that broke out in the nightclub in Brazil when burn surgeons had a massive number of patients, and the whole world came together to help them. We had multiple discussions in real time with surgeons in the front lines in the burn center. This is all Antonio's vision for the use of telemedicine in education. So thank you, Antonio.
You're here.
Absolutely.
Thank you, Raul. This is only happening because we have this amazing group of people, professors together. You are the one that, why you are president of the Panamerican Trauma Society, brought this to Panamerican Trauma Society. Dr. Scalea, while he was president of WCT, introduced this WCT so we can have all these lectures online, WCT and Journal of Trauma. He got approval for that. And this has been done through University of Miami for 10 years. And thanks my Dr. Namias to have a lot of people working behind the scenes like Valeria, Gary, and Gladys at the Panamerican Trauma Society. Is a lot of work, and this has been going for 10 years. So probably after all this goes away, you're going to publish the data for 10 years of meetings, more than 40 meetings every year discussing trauma cases with universities around the globe. Thank you, everybody. We just work together. It's a global collaboration supported by the Panamerican Trauma Society, the American Association for Surgery of Trauma, International Relations Committee, World Coalition for Trauma Care, University of Miami, and Virginia Commonwealth University, VCU. Thank you all for being here. Next week, we're going to focus on the recovery phase, the challenge that the places that are already in the recovery phase are facing. And I hope everybody stays safe and see you all next week. Thank you very much.
Thank you.
Thank you, guys.
Thank you for the opportunity.